All right, guys, welcome back. This is going to be session 3 of our conference. It's going to be entitled Work in Progress, Development and New Treatments, presented by Dr. Michael Levine, is MD Professor of Pediatrics and Medicine in Pittsburgh, Pennsylvania. Dr. Levine is Chief of the Division of Endocrinology and Diabetes and Director of Center of Bone and Health at the Children's Hospital in Philadelphia. He's a professor of pediatrics at medicine at the University of Pennsylvania, Perelman School of Medicine, and he holds the Lester Baker Endowed Chair in Pediatric Diabetes. His primary clinical interests are endocrine diseases that affect bone and mineral metabolism, particularly osteoporosis, primary hypoparathyroidism, rickets, and genetic bone disease. Dr. Levine has active laboratory research program and complements and extends his clinical studies. He has identified the molecular basis of several inherited disorders of mineral metabolism. He is a member of numerous professional societies, including the American Society of Bone and Mineral Research, American Society for Clinical Investigation, Association of American College of Endocrinology, the American Academy of Pediatrics. In 2018, Dr. Levine received the Frederick C. Barter Award from the American Society of Bone and Minerals Research. Since 2005, Dr. Levine has been named one of America's best doctors. He's a longtime member of our medical advisory board, and due to his work in genetics on my family, he's identified the genetic mutation that causes hypoparathyroidism in my family. So I appreciate the work that he's done on that. Without further ado, here is Dr. Michael Levine.
Well, good day, everybody, and thank you very much for that introduction and for the opportunity to spend some time with you talking about a work in progress. And I've called this What's on the Horizon for the treatment of hypoparathyroidism. If you have questions during my talk, please submit them, and I will try to answer your questions as we go along. I'll remind you of the summary of my talk. Neck surgery is the primary cause of hypoparathyroidism. As you've already heard, genetic studies have been important in identifying the basis of hypoparathyroidism in patients who sometimes are called idiopathic hypoparathyroidism. And these new genetic studies have not only identified known genes, mutations in known genes, but they've also revealed novel genes involved in PTH homeostasis and parathyroid development. So we're grateful to all of the patients with hypoparathyroidism and families who have participated in our studies, as well as studies by other investigators in the field of hypoparathyroidism, because without your participation and contribution, we would know far less than we do today about the parathyroid glands. I'll remind you that conventional treatment of hypoparathyroidism with active forms of vitamin D, such as calcitriol or 1-alpha plus calcium, may manage the serum calcium levels and phosphorus levels, but present a risk of hypercalciuria and renal insufficiency. And because of this, new approaches to the treatment of hypoparathyroidism continue to be needed. Now, there is a lack of PTH as the basis of hypoparathyroidism, and the lack of parathyroid hormone action leads to decreased production by the body of the active form of vitamin D, calcitriol, also called 1,25-dihydroxyvitamin D. Those of us who still have parathyroid glands are fortunate because PTH will generate calcitriol within our bodies, and this will allow us to absorb calcium in our diet or from supplements. And in the absence of PTH, a patient with hypoparathyroidism requires either PTH supplementation or supplementation with active forms of vitamin D. The lack of PTH also decreases the renal excretion of phosphorus, and this leads to elevated serum phosphorus levels. The absence of PTH also leads to increased excretion of calcium in the urine, and this can lead then to renal calcifications, nephrocalcinosis, stones, and declining renal function. And lastly, the lack of PTH action leads to decreased metabolic activity of the bone with reduced release of calcium from skeletal stores. In some, a lack of PTH action leads to hypocalcemia and hyperphosphatemia. The clinical manifestations, yes, we have a question?
We got two questions that
already
popped up. Yeah, one of them. Yeah, already. It says, what is the ideal timing for taking calcium, taking calcium, active vitamin D, magnesium, and vitamin D3? Should they be taken at the same time or spread out for best absorption?
All right. So vitamin D3 can be taken anytime during the day, and you only need to take the dose one time a day, whatever the dose is. Active forms of vitamin D, such as calcitriol, should be taken twice a day, morning and late in the day, and it doesn't matter if you take that with food or without food. So calcitriol twice a day, 1-alpha is taken once a day, and vitamin D3 is taken once a day. Calcium supplements should be spread out throughout the day and taken with food, because the calcium supplement also binds phosphorus in our food and prevents the excessive absorption of phosphorus. And there was a second question, Bob?
Yeah, it said, and it's regarding pseudohypoparathyroidism. It says, will the treatment be the same for pseudohypoparathyroidism?
So conventional treatment would work very effectively in pseudohypoparathyroidism, but you couldn't expect a patient with pseudohypoparathyroidism to respond to PTH treatment, because they are resistant to PTH, whether it's produced by their own body or given by injection. So patients with pseudohypoparathyroidism would be limited to conventional therapy, but patients who lack PTH on their own, or those very rare patients that are making PTH that is defective, so a bio-inactive PTH, they would also respond to PTH injections. Okay,
and then one more just popped up, and then we'll move on.
Okay.
And it's regards to different types of calcium. It said, are there any alternatives to calcium? I've tried algae calcium, but I was too scared to stay on and had my calcium drop. I read calcium can cause kidney stones and calcifications.
So all forms of calcium can cause kidney stones and renal calcification if the amount of calcium in the urine is excessive. So this then goes to the issue of monitoring therapy. And I think patients should be monitored regularly at 3 to 4 month intervals, serum calcium, serum phosphorus, serum creatinine to look at renal function, and then urine calcium, either a 24-hour collection or a random just spot urine for calcium and creatinine to look at the ratio. So as long as the urinary calcium excretion is not increased, then the risk of a renal calcification or stone remains low. And I think that there are many different forms of calcium. We call them calcium salts. Calcium carbonate is the most commonly used form of calcium because it has 40% calcium by weight. So a 1,000 milligram capsule of calcium carbonate has 400 milligrams of pure calcium. So it's the easiest way to get an adequate amount of calcium. But some patients may develop constipation or an upset stomach from calcium carbonate. So then calcium lactate, calcium citrate, many other forms are also suitable, but it's likely that more tablets will be required if you use these alternative forms of calcium, which is a good segue to clinical manifestations of hypoparathyroidism. And as we know, these are related to the low calcium level. And the spectrum is very broad. It runs from mild or asymptomatic state where there are no symptoms to debilitating symptoms of paresthesias in the fingertips, face, and toes to muscular cramping. And we know that there are tremendous differences from one individual to another in how many symptoms somebody may have, even at the same level of low calcium. And this is something that we're trying to teach doctors, that a patient with a calcium of 8 can be free of symptoms, while another patient with a calcium of 8 can have severe symptoms. But in addition to these neuromuscular symptoms that we've known about for many years, we're becoming more and more aware of brain fog, inability to focus or concentrate, even increased anxiety. And this accounts for a major reduction in quality of life. And I have to say, it's really been through the efforts of many of the members of the Hypoparathyroidism Association over the past 20 years that we have come to recognize many of these other manifestations of hypoparathyroidism. So what are the key features of parathyroid hormone and hypoparathyroidism? Well, we know that serum levels of biologically active PTH are low, although some patients will have levels of PTH that are within the normal range, but obviously too low to maintain their serum calcium level in the normal range and free of symptoms. And we also know that symptoms and signs of hypoparathyroidism result principally from hypocalcemia. There is a contribution of the high phosphate, which can cause cataracts and calcification in the brain. And many of us are now trying to understand whether some of the symptoms and signs of hypoparathyroidism may result from low levels of PTH, and that would not be addressed by conventional therapy of hypoparathyroidism. So that raises a question: does conventional treatment of hypoparathyroidism address all needs? And we've already talked about oral calcium salts plus activated vitamin D, and this can, in most patients, correct hypocalcemia and correct hyperphosphatemia. So another plug, remember when you're being monitored, you need to know your serum calcium and your serum phosphate. And conventional therapy has as its most significant side effect hypercalciuria, increased urinary calcium. And this can lead to calcium deposits in the kidney that are widespread, called nephrocalcinosis, as well as renal stones. And ultimately, this leads to decreased renal function. And then lastly, conventional treatment of hypoparathyroidism doesn't seem to fully address quality of life issues. Patients continue to note episodes of brain fog and emotional instability. So I think
we got a couple more. Oh, sorry.
Sure.
Sorry, Dr. Levine.
No,
got a couple more questions that
good.
popped up.
Good.
One, in regards to calcification, she was asking if they could be reversed.
So that's a great question. And in adults, there doesn't seem to be any evidence that we can reverse renal calcification. In young children, we often will see a reversal of renal calcification once the urinary calcium levels become normal. So it does seem possible to reverse calcifications in kids, particularly in the first few years of life, but in adults, there's no evidence that anything we do can reverse those calcifications. The best we can do is prevent progression of the calcification.
Okay, and then the other one that we have is, what is the ideal 24-hour urine value for women? And at what value is there an increased risk of kidney stones and or other kidney problems?
So the risk of kidney stones is proportionate to the amount of calcium in the urine. And that means that the higher the calcium in the urine, the greater the risk. But there probably is no absolute threshold below which somebody cannot develop a kidney stone. When we look at kidney stone formers in the general population, patients who have normal parathyroid hormone levels, normal calcium levels in their blood, about 40 or 50% of them have high urinary calcium levels, and about 50% have normal urine calcium levels that obviously are too high for them. So we say that this is a continuous spectrum of risk. The higher the urine calcium, the greater the risk. The lower the urinary calcium, the lower the risk. Now, what's a reasonable normal level? I think that most people think that up to 250 milligrams per day is the upper limit of normal for women, 300 milligrams for men. I think another way to look at this is on a weight basis. And we use the number 4 milligrams per kilogram. So you've got to convert your weight from pounds to kilogram. So for example, a man or a woman weighing 154 pounds weighs 70 kilograms. So 4 milligrams per kilogram is the upper limit of normal for everybody. And so that would be, I would use 300 and 250 for men and women. And then I'd also check whether on a weight basis, the urine calcium was appropriate. Okay, so I think these limitations of conventional therapy really have stimulated tremendous interest in replacing the missing hormone, PTH. And the early studies by Karen Weiner and others had shown that PTH 1 to 34 is very effective in children and adults, but requires multiple injections or even continuous infusion. Natpara, which many patients are taking or were taking until the recall last year, was FDA approved for the treatment of hypoparathyroidism, and that was a great advance over conventional therapy as a once-a-day treatment. You'll hear later during this conference about TransCon PTH, which is another form of PTH that is being developed for once-a-day injection treatment of hypoparathyroidism. And I'll remind you that right now, because of the FDA recall of Natpara, we don't have available to us an FDA-approved treatment for hypoparathyroidism. Many people are using Forteo off-label, but I'll remind you that it is not an FDA-approved indication. And no form of PTH is currently FDA-approved for children, but many of us have used PTH in kids, particularly those children who have forms of hypoparathyroidism due to activating mutations of the calcium sensing receptor, because that's associated with very high levels of urine calcium, and using PTH in those patients can reduce urinary calcium excretion. There are additional benefits to PTH replacement that go beyond more normal levels of calcium and phosphorus. We see normalization of bone turnover without seeing a reduction in bone density. In fact, parts of the skeleton actually show slight increases in bone density, so it's safe from the perspective of skeletal metabolism. We can even see preserved or improved renal function in patients who are using PTH compared to conventional treatment. So although a question was asked, can we reverse renal calcification and hypoparathyroidism? And sadly, I don't think that's possible, but it is possible to preserve or improve renal function by using PTH as compared to calcitriol. And then many of you who have experienced the transition from conventional therapy to Natpara, for example, have noticed an improvement in quality of life. And many studies have documented this using a variety of questionnaires, such as the SF36 questionnaire, where there's improvement in social functioning, vitality, energy, and overall mental health. So what are the limitations of current PTH treatments? Well, we know that Forteo PTH 1 to 34 has a very short half-life, requires multiple injections during the day or even continuous infusion. And the PTH 1 to 84 Natpara doesn't provide a continuous effect that lasts for 24 hours. Some patients who are taking PTH replacement continue to experience episodes of hypocalcemia and require a little bit of calcitriol or even calcium for rescue therapy. Many patients on PTH continue to have elevated urinary calcium levels, and this has, I think, inspired the studies of twice-a-day dosing of Natpara, and the early and preliminary data from those twice daily dosing studies show some continuing limitations, with many patients who are taking PTH twice a day plus calcium supplements continuing to have elevated urinary calcium levels. So many limitations. Current PTH analogs certainly represent a major leap forward in management of hypoparathyroidism, but they still have significant limitations. Now, to address some of these limitations, there's been a lot of work on developing better forms of PTH. There's a form of PTH called LA for long-acting PTH. It has a highly modified sequence of 1 to 34. Preclinical studies in rats and mice are very encouraging, and I'm hopeful that at some point this will move into clinical studies, and Michael Monstadt is part of the team developing that modified PTH, and he's talking later during this conference, and you could ask him questions about LA-PTH. Transcon PTH 1 to 34 is another novel form of PTH, and here what the company has done has taken PTH 1 to 34 and attached a linker to it, and this linker then binds the PTH to a large molecule called polyethylene glycol. And when the PTH is bound to the polyethylene glycol, PEG, it's inactive and it circulates with a very long half-life in the plasma, and then slowly the linker that couples the PTH to the PEG dissolves, releasing the active PTH, and then that active PTH is able to bind to the receptor and act as a fully activated form of PTH. And this kind of approach is able to provide levels of PTH that are similar to that achieved by continuous subcutaneous pump infusion. So I think it's an advance over currently available forms of injectable PTH, and we're looking forward to seeing the results of the phase 3 trial. But what I'd like to talk to you about this morning or afternoon, wherever you may be, is some new approaches to replacement with PTH. And these ideas are really twofold. One is an enterally absorbable, so an oral form of parathyroid hormone that would avoid injections. And number two, the development of parathyroid tissue from stem cells that could then be implanted within a patient to replace missing parathyroid tissue. So we'll talk a little bit about these two new approaches. So oral medications for hypoparathyroidism are being developed. Companies in Japan are working on small molecules that are not proteins, so they're not degraded in the stomach or in the intestine, and yet these small molecules can be taken orally. They'll be absorbed, bind to the PTH receptor, and these are under development. And I think there's some reason to be very hopeful that they'll be developed and approved for hypoparathyroidism. A company called Intera has developed an oral formulation of PTH 1 to 34. And the original goals were to see whether this would be effective for hypoparathyroidism as well as for osteoporosis. And because such a small percentage of the PTH is absorbed and the duration of action is so short, the company has now decided to move away from hypoparathyroidism and to focus on this form of PTH as a treatment for osteoporosis. But we're taking a different approach, a very different approach. And let me preface that by context. As you know, that there's an expanding cost of biopharmaceuticals. Even insulin has become enormously expensive. And the cost of biopharmaceuticals, hormones that are made in recombinant cells, is costing a tremendous amount of money. So for example, in 2013, the cost of biopharmaceutical drugs exceeded $140 billion. And this exceeds the entire gross domestic product of 75% of the world's countries. So we can't continue with business as usual, developing biopharmaceuticals that are outrageously expensive. Less expensive drugs are needed, drugs that are safe, effective, and can be manufactured at lower cost, which will lead to a lesser price at the pharmacy. So the current way biopharmaceuticals are made, here you can see fermentation of cells and then purification of hormone. This is how insulin is made. This is how PTH is made, growth hormone, many of the biopharmaceuticals. We're looking at a different way to produce these proteins using plants. And in this case, it's lettuce. So here's a lettuce leaf, and here is a tablet containing protein encapsulated in particles of lettuce. And I think this is going to be a way of the future that we can use plant-based manufacturing in order to produce proteins such as parathyroid hormone at significantly lower cost than our current production costs. And the way in which these proteins are made in the plant cell provides an encapsulation that improves absorption of orally taken proteins. And I've been fortunate here at Penn to be able to work with Henry Daniell in the School of Dentistry, and Professor Daniell has pioneered the use of plant-grown proteins as treatments for a variety of diseases. And in his laboratory, he's developed the ability to generate factor IX for hemophilia. He's developed a way to produce factor VIII IGF-1, and insulin. So these are all protein drugs that today are very expensive, require injections, and using his technology, you can generate these proteins in lettuce. So this is an example of what I'm talking about. You create a gene and you then insert that gene into lettuce, and you can see the little lettuce growing. And then you select the lettuce plant that is producing the greatest amount of the protein of interest. You transplant it into larger and larger pots, and then you're able to take these flowering lettuce plants and grow them in these enormous hydroponic propagation fields. This is an indoor example, a greenhouse growing tremendous numbers of lettuce plants. You harvest the leaf, you dry it just like Folgers coffee is freeze dried. And once it's dried, you see these little wafers. You can grind them up into a powder, fill them into little plastic capsules, and there you go. Capsules filled with ground up freeze dried lettuce leaves in which the protein of interest is within lettuce chloroplasts. And those chloroplasts protect the protein from the digestive enzymes. So we've been working now with Dr. Danielle to produce PTH in lettuce chloroplasts. And what we've done is select what we think is the best PTH peptide. We've created the gene and inserted this into lettuce plants. And we've selected a series of lettuce plants that are producing PTH in reasonably high concentrations. And now we're beginning to study that PTH. So this gives you an idea of parathyroid hormone. You know that PTH is produced by the PTH gene, and it's made as a pre-pro PTH, a large precursor. And as this moves through the parathyroid cell, and it's stored in granules as 1 to 84. So we've taken is there a question?
Yeah, there's a couple. I was just going to say
right.
we got about 5 minutes left, and
okay,
there's a
almost
couple
done.
that are stacking up. I figured we could take 10 minutes or so.
All right.
In just
okay.
a few minutes.
Well, I'm almost done, but go ahead. You have if you want to have
okay.
I can answer 1 or 2 questions now.
Well, let's go ahead and finish that, and then we'll start going back.
All right. So what we've done is created a form of PTH and that is fused to another protein that will bind to receptors in the intestine. So the PTH is made as a fusion protein that has the parathyroid hormone attached to CTB. And this CTB doesn't affect the function of PTH, but binds very tightly to receptors on intestinal lining walls. And here you can see this in green shows you another protein that's labeled with green that's bound to intestinal cells after ingestion of this oral protein. So for PTH, we've been able to achieve this, growing it in the lettuce. This shows you a Western blot of the PTH with the CTB linker. So we've developed lettuce. The lettuce produces the PTH, and we've actually now given mice this ground up lettuce containing the PTH. And I'd love to tell you that our first experiment was successful, but it wasn't. There was no change in serum levels of calcium or phosphorus, no changes in serum levels of PTH. And we think this is because we didn't give enough of the lettuce produced PTH. And so now we're working on making lettuce plants with more concentrated PTH. So stay tuned. I'm convinced that this is going to be a winner, but it's going to take a little bit more time. And now let me just give a couple of slides about what I think is even more exciting than that. And that is a different approach to treating hypoparathyroidism, and that is to replace the parathyroid glands. Rather than giving people PTH by injection or even oral PTH, why not give hypoparathyroid patients new parathyroid glands? Well, if you've had an operation and the surgeon has saved some of your parathyroid tissue, then you could have what's called an autologous parathyroid transplant, where they take some of your saved parathyroid tissue and place that into your forearm, and that's successful about 50% of the time. But most patients with hypoparathyroidism don't have their own parathyroid tissue stored away someplace, so it's not available. Allogenic parathyroid tissue means parathyroid tissue from a cadaver or a donor, and some patients have had allogenic parathyroid tissue transplants, but they have to take anti-rejection drugs, and some of those drugs can cause bigger problems than hypoparathyroidism. So there hasn't been a lot of enthusiasm for doing allogenic parathyroid transplants. We've taken a different approach. We believe that stem cell technology that's being used to create lungs and hearts and nerves, we believe stem cell technology may allow us to create functional parathyroid tissue from cells that are embryonic or from cells taken from the patient themselves. And we've just published a paper in endocrinology with Betty Lawton and Diane Krause. And Diane will be talking later during this conference about stem cell work. I'll just give you a little glimpse into this because we think this is another very encouraging set of experiments. We've taken cells that are either embryonic stem cells or adult cells from patients and been able to reprogram them into pluripotent cells. This means cells that can become any tissue in the body. And the goal is to take stem cells from either a patient or from a culture source, and to make these cells into parathyroid cells that can then be transplanted and restore normal parathyroid function. So how are we doing? So far, using embryonal stem cells that are off the shelf or stem cells from adult patients that have been induced to become more like parathyroid, we've been able to demonstrate expression of PTH in these cells. So beginning very little PTH, and by day 36, tons of PTH, expression of the calcium sensing receptor, and GCM2, a parathyroid marker. So with Diane Krause and Betty Lawton, we've been able to develop a reproducible protocol that is able to take stem cells and induce them to become differentiated into cells that can produce PTH and cells that express the calcium sensing receptor. And now our goal is to expand these cells into large numbers to study the calcium regulated release of PTH in vitro to make sure the cells release PTH in response to low calcium and turn off PTH when calcium is elevated. If that's something that we can demonstrate, then we'll transplant those cells into hypoparathyroid mice and make sure that we have recapitulated normal parathyroid function. So stay tuned. So in summary, hypoparathyroidism is an uncommon but important endocrine disorder with significant clinical impact, and nobody knows that better than the group listening to me today. PTH and PTH analogs certainly offer new options for management, a step forward, a true advance over conventional therapy, but limitations exist. We believe that oral formulations of PTH manufactured in lettuce may offer important benefits in cost and in efficacy. but that ultimately stem cell-based approaches to restore normal parathyroid gland function will be our ultimate goal. So I'll acknowledge the people who have helped me with this work at CHOP, Corinne Martineau and Chelsea Databo, at Penn Dental, Henry Danielle, at Yale, Betty Lawton and Diane Krause, and UCSF, Julianne Sosa. So thank you very much for your attention. And if there's time, and I hope there is, I'll be delighted to answer questions.
Yeah, we got quite a few. It's up to you, Dr. Levine.
Yeah, let's go. Let's
kind of roll into the lunch.
Yeah,
a little bit to get these in.
Let's do it. Yeah.
Okay, because I know we got lunch starting in about 5-10 minutes, guys. So if you want to stick around, you can, and then we'll go with that. So, kind of going. There was one, and she asked if she said, "What if you have a lettuce allergy? Is that going to affect the plant-based side?"
So that's a great question. Right now, lettuce allergies are thankfully very rare, but I'm sure some people have true allergies. And as it turns out, in a series of experiments in which lettuce that is used in these experiments was given to dogs, they've been able to show desensitization to those immune responses. So there is, I think, some reason to think that by taking the lettuce, you can become desensitized and overcome the allergy. But good question.
Okay, and this one goes with malabsorption. It says, so if someone has a malabsorption problem, it could then make meds less effective or not work correctly. And in regards to that one, another person wrote, would this be effective for a gastric bypass patient or a patient with absorption issues?
So great questions. It's hard to know. I think we would have to do experiments. And, the first group of patients that would be tested would be individuals with normal GI tract. And then at some point moving forward, there could be studies in patients who have either malabsorption or reorganized GI tracts, such as after bariatric surgery. So it's an unknown at this point.
Okay. Would lettuce pill work for non-surgical folks? I was born with PTH glands.
So that's a great question, and it really depends upon what the problem with the PTH gland is. So there are about 5 families in the world in which hypoparathyroidism is due to production of a PTH molecule that is not functional. It would work in those patients. There are other patients who have parathyroid glands, but they don't release PTH appropriately. And there may be better treatments for those patients using new drugs that target the calcium sensing receptor. And there are others who are attending the conference who are presenting and may address that fact. So I think that based on what the cause of hypoparathyroidism is, there may be targeted therapies that address the defect in the parathyroid, or something like lettuce PTH would be the answer.
Okay. And then how much more time before the oral PTH treatment might be available?
That's a great question. I would say that we need another year or 2 of preclinical development, and then if everything was successful in preclinical, so that means with mice and other animals, we could move into humans. So probably you're talking 5 years. I know it's slow, and I wish it were faster, but you can't, some things can't be rushed, and growing plants and doing molecular biology takes time.
Okay, let's see what we got. There's quite a few, and people, we're get as many of these answers as we can, and what we don't have time for, we'll go ahead and issue these to Dr. Levine and get them out to you as well. This one says, what do the extra 50 amino acids in the PTH 1 through 84 offer that the PTH 1 through 34 lack?
Yeah, so that's a great question. All of the biological activity that we know about is in the first 34 amino acids. My gut feeling is that there are probably some other functions in that C-terminal tail. There's a region that may be important for controlling bone turnover. It's been called osteostatin. No one's been able to find the receptor for that portion of PTH yet. But you know, nature doesn't do any more work than she has to. And if everything was in that 34 amino acids, I think that's what our parathyroid glands would make. Why would the parathyroid gland go through all the additional effort to make 84 amino acids if 34 were all you needed? So we based our 1 to 84 on nature knows best.
Yeah. And just to kind of close it out, it says, I think Dr. Michael Levine is our hypopara rock star. Thank you.
Very generous. Thank you so much.
Again, we'll save all these other questions and we'll get them out to you, Dr. Levine, and once we get them answered, we'll put them on the website for everybody to see.
All right. Thank you very much, Bob. It's good being with all of you today, and enjoy the rest of the conference. Stay safe and don't forget to vote.
Yeah, and we'll see you guys in an hour. Go ahead and enjoy your lunch. And thank you again.